So we're going to be starting or continuing actually with chapter 6. This is a part B on bones and skeletal tissue. So now for bone development, the terms osteogenesis and ossification, they're synonyms, so they're used interchangeably. This describes the process of bone tissue formation. Now, in the embryo, this process, the process of ossification, it leads to the formation of the bony skeleton, and this starts at the 2-month mark. So right around the 2nd month of development. And remember, this is called prenatal development. Okay, so prenatal means before birth. Postnatal, post means after birth. So postnatal bone development, bone growth, it continues well into early adulthood. The process of bone remodeling and bone repair is ongoing. It's lifelong. So again, even after postnatal bone growth stops, remodeling continues throughout your life. It doesn't end. So the formation of the bony skeleton, at up to about 8 weeks, the fibrous membrane and hyaline cartilage of the fetal skeleton, they're replaced with bony tissue. So when the bone, when it develops by replacing hyaline cartilage, we call that endochondral ossification. Okay, and the bones, they're called the cartilage or endochondral bones. All right. Now the other type is this intramembranous ossification. As the name implies, this type of bone development occurs from the fibrous membrane, and these bones are called the membrane bones. Now, the difference between these two we're going to be looking at in detail in a little bit, but in a nutshell, most of the flat bones, these are these intramembranous ossification. These bones develop through intramembranous ossification, while the majority of the bones that make up your links, the long bones, they tend to be endochondral, developed by endochondral ossification. For endochondral ossification, this this forms just about all your bones in your body that's below your skull. The exception being are your collarbones, your clavicles. It starts in the later part of the 2nd month of development, and it uses the previous bones, this hyaline cartilage that was formed earlier on, as a model or a pattern for the bone construction. It's more complex than intramembranous ossification because the hyaline cartilage, it has to be broken down in order for the ossification to proceed. We're going to be looking at, we're going to be talking about both these things in details as we move forward. But this process, it starts at a primary ossification center. Okay, and this primary ossification center is found in the center of the shaft of the bone. So what happens is blood vessels, they infiltrate the perichondrium, and once that happens, it converts it into a periosteum. Okay, so once you get blood vessels coming in, it brings life. In other words, it kickstarts this bone formation process, this ossification process. The mesenchymal cells, they specialize into the osteoblasts, and remember, these osteoblasts, these are the bone building cells. Now that you've got these mesenchymal cells that are starting to specialize into osteoblasts, and you got the blood vessel that's come in there, and all the processes kicked off. Let's look at how the next steps occur. What happens next afterwards? So there's 5 steps that are in the process of ossification. The very first thing that happens is this: the osteoblasts, they start secreting osteoid against that hyaline cartilage diaphysis. And what this does is that the bone now becomes encased as the eye cells are being pushed out. Now, once that happens, that freshly formed layer of bone, that's what's called the periosteal bone collar. Okay, so the next thing that happens is this: step number 2. So as the collar forms, the chondrocytes that are found within the shaft, they enlarge and they signal the surrounding cartilage matrix to calcify. Now, because the cartilage matrix is now calcified, nutrients, they can't diffuse through, so it's impermeable. And then what happens is the chondrocytes, they end up dying because it's they're not able to get their nutrients. and then eventually the entire matrix starts to deteriorate. Now this, when it starts deteriorating, it ends up opening up cavities. But however, now the hyaline cartilage, it's stabilized by the collarbone that's there, okay? So it's not going to just fall upon each fall down. But now remember, this is just happening in the shaft, okay? Now, other parts in the cartilage, that's still healthy and it's going to continue to grow. Usually what happens, how it's going to grow is that it's going to get longer. So it's going to elongate. But at this point, all the changes taking place within that shaft. So now we go on to the third step, number 3. So the cavities we had from the previous step, they start getting invaded by periosteal buds. Now these periosteal buds, they contain the nutrient arteries, veins, lymph vessels, nerve fibers, red marrow, osteoblasts, and osteoclasts. Now these osteoclasts, they start partially eroding the calcified cartilage matrix. And the osteoblasts, they start secreting osteoid around the remaining fragments of hyaline cartilage. Now when they do this, it starts forming bone-covered cartilage trabeculae. And that's how you end up with spongy bone. Now, for the fourth step, as the primary ossification center enlarges, osteoclasts, they break down that newly formed spongy bone. And when they do this, it opens up a medullary cavity in the center of the diaphysis. Now, up until the 9th week, the epiphysis it's made up of only of cartilage. And hyaline cartilage model, it continues to elongate by the division of the cells at the epiphysis. Now, ossification, it chases this cartilage formation along the length of the shaft. As cartilage calcifies, it gets eroded, and then it's replaced by these by bony spicules on the epiphyseal surfaces, facing the medullary cavity. So this is how we start seeing this secondary ossification centers to appear. So in the 5th step, what's happening is this: the cartilage in the center of the epiphysis, it calcifies and it deteriorates. When this happens, it opens up cavities that allow the periosteal buds to enter. Now, what's going to happen at this point is the same thing that happened in step 3 over here. Because remember, you got blood vessels, nerves, red marrow, osteogenic cells, and osteoclasts. So essentially what happened over here is now going to, almost the same thing is going to happen over here. The exception being is this though. There's not going to be a bone marrow that's formed, okay? You're not going to get a medullary cavity. Instead, you're going to end up getting all spongy bone over here. So the bone trabecular pair, and then you have spongy bone at this point. Now, with secondary ossification, when it's complete, hyaline cartilage, it remains only in 2 places, okay? On the epiphyseal surface as articular cartilage, and at the junction of the diaphysis and the epiphysis, where it forms the epiphyseal plate. So in this picture, what we have going on is this. The osteoblasts, they're starting to secrete the osteoid, and then what you end up having is you're starting to get this bone color that forms over here, all right? And this is kind of what's keeping this entire structure in shape, okay? It's preventing it from falling upon itself. And then you have this primary ossification center also that you start to see. Now, moving forward past week 9, what we're having is this. The cartilage in the center of the diaphysis, it's starting to calcify, okay? Once it starts to calcify, it starts to make this cavity. Now, this 3rd step is this. When you start getting these cavities, now you have room for these the periosteal buds to come and invade. So now what do you have? You got blood vessels coming in, nerves, and then you have these osteoblasts and osteoclasts. So in other words, at this point, now things are going to start. You're going to start seeing a dramatic change over here, because now you just got the lifeline of blood vessel. Okay, remember blood. All the everything gets transported through blood, through the blood vessels. So now let's see what happens next. In the 4th step, what you see is this. Notice that you have a cavity that forms now. Because remember, the osteoclasts, they came in, they start chewing away all the tissue that was there. Now we have osteoclasts. Again, you got the blood vessels that further start to expand and they start creating this capillary. Also, you're starting to see these secondary ossification centers. They're not quite developed yet. That should be in they start to form over here. However, when you go to the 5th stage over here, and this will happen after birth, or sometimes right before birth. This is when these epiphyses, they will ossify. So now the main difference is this, at this point, is that you end up getting these blood vessels. So when these blood vessels, they enter, then you end up, you get the spongy bone that starts to form over here. Now the main thing over here is this, that over here where we had when the periosteal buds entered, same thing happened here. You have the periosteal buds enter over here also. However, over here it formed the medullary cavity. But at the epiphysis, you're not going to get these cavities forming. You're just going to end up with spongy bone. Okay, so now once that happens, once the epiphysis, it calcifies, the only place you're left with cartilage is at the epiphyseal plate and at the end of the bone. So it's articular cartilage over here, and then the epiphyseal plate cartilage over here and over here. Okay, so remember, these are the epiphysis. The epiphysis is the area between the epiphyseal plate. It's the area. It's what separates the epiphysis from the diaphysis. Okay. Now we're going to be talking about intramembranous ossification. So intramembranous ossification, it begins within the fibrous connective tissue membrane that's formed by the mesenchymal cells. Now remember, these mesenchymal cells, they are able to specialize into other type of cells, just like we saw in the previous scenarios with the endochondral ossification. So we're going to be seeing a lot of that, somewhat similar stuff going on over here also. The process is relatively similar, and we're going to be talking about that. But now, before we get to that, keep in mind that intramembranous ossifications, it forms the bones of your skull, your clavicles. In addition to that, your jaw bones also, your mandible. So the four major steps that are involved are as follows. Now, ossification centers, they formed when these mesenchymal cells, they start to cluster, and then they start to aggregate. And then they specialize into these osteoblasts. All right. So as they once they specialize into osteoblast, at that point they start secreting osteoid. So remember, this osteoid is going to end up being the matrix. So once that osteoid is secreted, then after some time passes, it starts to get calcified by calcium and other mineral salts that come in. Now the next step, number 3, what happens is the woven bone is forming at this point. Now, this happens when the osteoid is laid around these blood vessels. So these osteoids, when what you have are these primitive embryonic blood vessels. So when these osteoids, they start laying themselves around it, then you end up starting getting these bones that form around these blood vessels. So, and these bones are called these trabeculae, right? And this is going to be essentially what you end up having to be the remnants of this spongy bone. Now, at the same time as this is going on, what's also happening is the outer layer of the woven bone, it forms the periosteum. Now, what's going to happen is this, in the next step, is that lamellar bone, it's going to end up replacing these woven bone, and the red bone marrow starts to appear. So let's look at what happens graphically of the previous steps that we just went over. So in the very first center, what's going to happen is this. You have these mesenchymal cells. Now these mesenchymal cells, they end up specializing into these osteoblasts. All right. Now, after these the mesenchymal cells, they turn to these osteoblasts. They start to aggregate. They start to cluster up. And when they start to form, when they start clustering up, this is when you end up getting what we call this ossification center. Okay. Now, in the second step, what happens is that these osteoblasts, you can see over here that they're starting to secrete these osteoids. Okay. Now, these osteoids, you saw over here that they started to secrete this. However, it's over here that there's further secretion that takes place, and then what ends up happening is as the calcium and other mineral salts, they start to come in, these osteoids, they start to harden up. So in other words, it starts to calcify. Now, the other thing that you see over here is this, in this picture over here. Now it's in step 2. Some of these, two of these, in this case right here, two of these osteoblasts, they ended up coming to the center. And now what ended up happening is this: as this the ground matrix, as it calcified, these cells, they turn into, or they were further able to specialize and turn into osteocytes. These are the cells that are eventually that's going to maintain this bone cell. Okay. Now in the third step, let's see what's going on over here. Now in the third step, what's going to happen is this. Notice what we have going on over here. So one of the main things that we see that's different from here to there is now we're starting to see these cavities that are forming. In addition to that, you see these blood vessels that are coming in. All right. Now, these osteoids that have been accumulated, that are laid down between these embryonic blood vessels, they start to form these trabeculae. Okay, or in other words, what we call this woven bone, which is essentially going to end up being the spongy bone. So the vascular mesenchyme condenses on the external face of this woven bone, and it ends up becoming the periosteum. So in the next step, again, you can see over here what's happening. This mesenchyme is now it's turned into this fibrous periosteum. Now, the osteocytes that you have that are at the edge of these the trabeculae. So again, the trabecula that's just deep to the periosteum, they end up turning into these lamella, into the lamellar bone. Okay, so they further, again, through the process of remodeling, they end up specializing and they turn into this lamellar bone that you see here, or the compact bone. Now the spongy bone, the diploid, it's made up of these what we call the trabeculae. All right, and what it is essentially, it ends up forming these compartments that go around these blood vessels, and that ends up becoming this red bone marrow, or the red marrow. So in postnatal bone growth, so after you're born, again, during infancy and youth, long bones, they grow lengthwise. So they lengthen entirely by interstitial growth of the epiphyseal plate cartilage, and then it ends up getting replaced by bone. So all bones, now when we're talking about how they grow in diameter and thickness, this happens through appositional growth. Now bone growth, it stops during adolescence. Towards the end of your adolescence, this is when it stops. In boys, it's usually around the age of 21, and then in girls or in women, it's at the age of 18. However, some of the facial bones, they continue to grow throughout your life. So let's take a look in growth in the length of long bones. Now, these events in longitudinal bone growth, they mimic a lot of the stuff that goes on in endochondral ossification. Now, in order for interstitial growth to occur, you need to have the epiphyseal cartilage within the epiphyseal plate. Okay, so the epiphyseal plate, it maintains a constant thickness. Now, how it does is that the rate of the cartilage's growth on one side gets balanced out by the bone replacement on the other side. Now, you're going to be, as we go through these steps, you're going to understand what this means and how this occurs. But there's 5 zones within this epiphyseal plate: the resting zone, proliferation zone, hypertrophic zone, the calcification zone, and the ossification zone. So the very first part now, the resting zone. Now, this is a part of the area of the cartilage that's on the epiphyseal side of the plate. Okay, so now one of the things that you guys need to understand is this: do not forget the terms. When we're talking about the epiphysis, we're talking about the ends of the long bones, right? And when we talk about the diaphysis, we're talking about the long part, okay, the area between the epiphysis. Now remember, in long bones, what do you have? You have the ends. So the ends are this epiphysis, and the middle part, this is the diaphysis. So now, what they're saying over here is this: the cartilage that's on let's look at a picture before we go over here, so you guys have a better idea of what's going on. So when you look over here, this is the epiphysis right over here, okay? The epiphyseal plate. So now the cartilage, and this is what they're talking about when you're talking about the cartilage that's facing the epiphysis side. So that's up here, and the cartilage that's facing the diaphysis side. This is the part down here. So remember, this is the epiphyseal plate, and this is the area that we're talking about now. So let's go back up over here now, back to number 1. And so what they're saying is that, the area of cartilage on the epiphysis side of the plate is relatively inactive. However, the cartilage that's facing the side of the diaphysis, okay, this is, in this zone, it's not inactive. This side is actually dividing quite rapidly. Now, this represents a different zone, and this is called the proliferation zone, or the growth zone. So let's go back to this to that slide over here. Now, this is the part that we're talking about. This resting zone. This up over here. Okay, this very top part. But now, when you look over here, this is this very active zone, the proliferation zone, and these cells over here, they're undergoing mitosis. It's a highly mitotic area. So as these cells are dividing, they start to accumulate in stacks. So it kind of looks like stacks of coins. Now, as this is happening, the ends of the bones are starting to get pushed away. So what's happening is that the diaphysis is lengthening. So as more and more cartilage is being, these cells are being added, which takes us to the next part of the next zone, zone number 3. So as the chondrocytes in the proliferation zone, as they continue to divide mitotically, and you end up getting this lengthening taking place within the cartilage, the older chondrocytes that are now close to the diaphysis, they start to get big. They start to enlarge. Okay, and when this happens, this is starting to set up everything for the next stage, because as they're enlarging, the lacunae for these chondrocytes, they start to erode. All right. Now this leaves these large interconnecting spaces. So when you look at the next stage, the calcification zone, the surrounding cartilage matrix, it calcifies, and these chondrocytes, they die, they deteriorate. Now you have, and this is why we call it this calcification zone. So this leaves these long, these spicules of calcified cartilage at the epiphysis, diaphysis, the junction. So what's going to happen now in this next zone, this ossification zone, at the spaces from our previous step, they get invaded by marrow elements from the medullary cavity. Now, the cartilage spicules, they get partly eroded by the osteoclast, and then they ended up getting quickly covered with new bone. And we call this new bone the woven bone by the osteoblast. Ultimately, it gets replaced by spongy bone. The spicule tips, they eventually get digested by the osteoclast. This way, you end up getting a medullary cavity that also grows longer as the long bone starts to lengthen. During growth, the epiphyseal plate, it maintains a constant thickness because the rate of cartilage growth on its epiphysis facing side ends up getting balanced by the replacement with the bony tissue on the diaphysis facing side. Now we're just going to go and look at everything that we just discussed with this picture, and it's going to better help explain what we just talked about in those steps, in those 5 or 6 slides, however many slides that we had. So remember, this is the epiphysis, this is the diaphysis, okay? The junction between the epiphysis and this diaphysis over here, you have this this epiphyseal plate, okay? And remember, you have cartilage over here between these two, well, within this area. Now, no cartilage, this is not going to happen. Now, so we're looking at this, magnifying this. Now, the other thing that you notice there's only 4 steps here, but remember there was 5. They kind of screwed the slide up a little bit, and some of the information, in my opinion, is not very accurate, or it's not very clear. So this should be number 1. This should be 2, 3, 4, and 5. Now, remember, in the first stage, in number 1, this resting, in the resting zone, where the resting cartilage is, this kind of looks like hyaline cartilage also. If you look at it, it resembles that. Now, this resting cartilage over here, it helps secure the epiphysis to the epiphyseal plate. All right, the epiphyseal cartilage to the epiphyseal plate. Now, also, some of these cells that you find here, the chondrocytes, they're going to help contribute to what's going to what's going to take place in number 2, okay, at the proliferation zone. So in step 2, the chondrocytes over here, they're undergoing mitosis, okay, rapidly undergoing mitosis, and as these cells are dividing, okay, they start to align themselves into columns. So they kind of resemble these stacks of coins. And these stacks, they run parallel to the diaphysis. Now, because of this is how this bone is lengthening at this point. All right. Now in the third step, what's happening is these older stacks that we've had. So if you look over here, again, these are these cells, and there's a stack here, there's another stack here, there's a stack over here. So these are these stacks that we're talking about. So as these are lengthening, what's happening is this part is getting pushed upwards, right? So this part is getting further away from the epiphysis as it starts to lengthen, all right? Now, as this is occurring, the older chondrocytes over here in step number 3, they start to enlarge. So you can see over here what's happening. The cells are starting to get really big. They're starting to undergo hypertrophy over here. Now, so also at this point in the third stage, these cells are not dividing anymore, right? So the only thing that's happening is that they're growing in size. At the same time, the lacunae, they're starting to get thin, right? And so they're starting to erode. When you go down to the next stage, 4, in step 4, so step 4, if you look over here, there's only roughly between 2 to 3 cell layers thick. This is how much, how large this area is. So you're going to find a few layers of cells over here in the fourth stage. And remember, this is called the calcification zone. So already we had in the previous step, we had these cells that are starting to get big. They're starting to enlarge. Their lacunae, they're starting to get eroded out. Well, now this is setting up the stage for this for the fourth part. At this point, what's happening is the mineral, the calcium, phosphorus, they're starting to get deposited now. All right, this is what's happening. Calcification. This is why you call it the calcification zone. So the matrix, it calcifies. The cells, they're in the process of starting to die out now. Now, when you get to the fifth stage, step over here, the ossification zone, the cells are dead over here, right? The cells are dying. The walls, they're broken down between the lacunae in these columns, and now you have these spaces over here that are formed. If you can see the spaces over here, now right over here. So what's going to end up happening is this: within these spaces, they get invaded by these capillaries and these osteoprogenitor cells. So these osteoprogenitor cells, they give rise to either osteoblasts and osteoclasts. Now, the osteoblasts, they're going to start laying down the new bone matrix. Okay, that's going to be eventually gets turned into the ossified zone, and the osteoclasts, they start breaking down. So the spicules that we're talking about from the previous steps, they ended up getting broken down by the osteoclasts. Right, so this is essentially what's going on in this this step, or how these 5 steps grow in the lengthening of bones. Okay, so you got nothing much going on over here in the first step. Okay, this resting zone, except you have those chondrocytes that are helping to the second stage. The cells that you find over here, they're kind of assisting them, but nothing much is there. Remember, their main job is to help secure the epiphysis to the plate. Now in this step, once again, remember what's going on is these cells they're undergoing mitosis, right? So they're dividing constantly. As they're dividing, they form these stacks, or these long columns. And as these columns get larger, it moves the cartilage further away from the epiphysis. So now you're getting the lengthening in the bone that's happening. So as you get more and more cartilage that's forming over here, it's going to eventually get ossified, all right? So this is what they're talking about. As more cartilage is laid down, the ossification occurs. You get more cartilage and then more ossification. So again, let's just kind of go down. Again, this is how this bone is going to lengthen. So the next step, the third step, which is number 2 over here, The cells now, these stacks, you see what's happened to them. They change in shape. This is starting to get big. The lacunae, they start to thin out. They're starting to deteriorate. So in the fourth step, as these lacunae are deteriorating, what's happening is that the cells, they've enlarged. The lacunae is starting to thin out. Now the salts are starting to come in. Okay, the minerals are coming. So the calcification is taking place. At this point, these the chondrocytes, they're completely die out. Okay, they're completely dead. The matrix is deteriorating at this point. And then in the fifth step, finally, you get the blood vessels that start to come in. And now you got osteoblasts and osteoclasts. They start coming in and they start laying down and breaking about the old matrix and building up the new matrix, laying down the new bone, right? So as this, the next slide, as it says, towards the end of adolescence, the chondroblasts, they're not dividing as often, okay? So that their activity decreases. The plates, they start to thin out, and then it gets replaced by bone. So at this epiphyseal plate closure, this happens when the epiphysis and the diaphysis, it fuses. Now, when does this end? So in other words, when does bone lengthening stop? Well, in men and males and females, it's a little bit different. Females, it occurs a little bit earlier. So right around the age of 18, you'll notice that in females, they will not grow anymore. So in males now, this usually occurs right around when they're 21 years of age. So at this point, you're not going to see any more growth. So again, how do you find out for sure if you're going to grow or not? Remember, it says usually occurs around. If you go get an x-ray, all right, and they take an x-ray, the radiologists, they can tell if there's closure at the epiphyseal plate, all right, or not. So if there's still cartilage over there, that means you're still going to be growing. If there's not, if it's closed, that means you're not going to grow anymore. In other words, that's the end of the line. You're not going to get any taller. So yeah, females right around 18, they stop. They're not going to get any taller. So if you're 18 years old, you're past 18, you think you're going to grow more, you're going to get taller. Chances are probably not going to happen. Same thing for men. If you're right around the age of 21, most likely you're not going to grow anymore. That's it. You've reached the end of the line. So the growth and width, bones, as you already know, bones grow in width through appositional growth. This occurs throughout your life. Now, bones will thicken in response to an increased stresses from muscle activity or from additional weight. Osteoblasts that we find beneath the periosteum, they secrete the bone matrix on the external bone. And osteoclasts, they remove the bone on the endosteal surface, okay, from within the bone. Now, usually what ends up happening is more bone building takes place than bone breaking. So this ends up leading to a thicker and a stronger bone. And again, it helps that it doesn't end up being too heavy. At the same time, you end up getting remodeling taking the same place. So if you look over here, what's happening is, so bone growth. Now, what are they saying over here? So the bone gets replaced by cartilage over here for bone growth. Okay, when bone grows, of course, you get cartilage grows over here on this end. Bone replaces the cartilage down over here. Bone replaces the cartilage over here. Now in bone remodeling, what's happening is the cartilage stays here. Okay, the cartilage is not growing. So where you have cartilage growing over here, you don't have that over here. No cartilage in bone remodeling. The epiphyseal plate is right over here again. They're both the same. Now, appositional growth. Now, you can see over here, it's adding bone over here. So again, now what's happening over here? The bone is starting to widen out. All right. Now, the bone that was inside, it ends up getting resorbed. Okay, it gets broken down. So as bone's being broken down here, it's end up getting laid down outside. Okay, so this is how we're talking about bone thickening and remodeling. You end up getting the old bone eaten up from within, and the new bone getting added from the outside, the outer part. Okay. So we've said that bone growth occurs throughout your, from infancy all the way into your adolescence. So right up until about 18 to 21, your bones stop growing. The epiphyseal plate is formed. You're not going to grow anymore. Now, what you have to understand is this bone growth is very, very smartly controlled by a handful of hormones, okay, that are all more or less working together. So during infancy and your early childhood, the most important hormone is growth hormone, and this stimulates the epiphyseal plate activity. All right. The second hormone is this thyroid hormone. Now, this thyroid hormone, it works in conjunction with growth hormone. Okay, so it modulates the activity of the growth hormone, making sure there's proper proportions. Now, the next hormone, testosterone, these are also known as the sex hormones. So in males, you're talking about testosterone, and females, you're talking about estrogen. Okay, so this promotes adolescent growth spurts. All right, and also this hormone towards the end of adolescence, it starts the epiphyseal plate closure from occurring also. So it ends the growth, this testosterone. Now, having too much or too little of any of these hormones can cause, among other things, abnormal skeletal growth. Now, so between 5 to 7% of our bone mass is recycled weekly. So spongy bone gets replaced between 3 to 4 years. Compact bone gets replaced about every 10 years. Now, bone remodeling, what it consists of is both bone deposits and bone resorption. In other words, you're building bones and breaking away bones. Resorption means to break away, and deposit means to build. Okay, building and breaking bone. So this happens at the surface of the periosteum and the endosteum. When we're talking about remodeling units, so these are packets of adjacent osteoblasts and osteoclasts that are remodeling, that coordinate this remodeling process. So let's talk about bone deposit now. Now, bone deposit, this is going to happen whenever there's injury to the bone, or the bone needs to be strengthened further. Okay, so again, if you're starting to build more muscles, more stresses on the bone, then you need to have more deposit taking place. Now, for optimal deposit to occur, you have to have a good diet as well. So a diet that's good and rich and high in proteins, in vitamins A, D, and C, and also you want to have a lot of minerals. So you want to have enough calcium and phosphorus, of course. Okay, among that you want magnesium and manganese also, amongst again many other minerals. So again, you have to have a very good, healthy diet for that's required in order for this bone deposit to occur. So also, when you look at people that are bodybuilding, they want to get muscles, one of the things that they have to look at worry about is also to get first of all a very high calorie diet, but amongst that high calorie diet, they need when you get to the chapter of muscles, you're going to understand. They need to have a lot of amino acids, so a very high protein diet. But in addition to that, they have to have their vegetables as well. And one of the reasons they need to have a lot of vegetables in their diet is because the vegetables, they are sources for all these minerals and vitamins. So moving forward, so the new bone matrix, it gets deposited by osteoblast. Okay, now the bone matrix that are deposited by the osteoblast, they get marked by a presence of a seam that we call an osteoid seam, which is unmineralized band of gauzy-looking bone matrix. So between the osteoid seam and this older mineralized bone, you have this abrupt transitional zone that we call this calcification front. Now, because the osteoid seam is always of constant width and the change from unmineralized to mineralized matrix is sudden, it looks like that the osteoid must mature for roughly a few weeks before it's actually able to calcify. Now, how long it takes to calcify, that's kind of tricky, okay? But what we do know is that we have to, there are triggers. So the question is this: what are the triggers for calcification to occur? That's the correct thing to ask. So this is what we believe are the triggers for the calcification to occur. First of all, it could be mechanical signals. An increase in the concentration of calcium and phosphate ions for hydroxy apatite formation. That could be a trigger. The other thing to think about is our matrix proteins that bind and concentrate calcium. In addition to that, proper amounts of the alkaline phosphatase. Okay, this is an enzyme that's required for mineralization to occur. So when we're talking about bone resorption, we're talking about bone breaking, and bone resorption is a function of osteoclast. Now, what we find over here is this. These osteoclasts, we find them clinging to the bones, and when they cling on, they kind of they end up forming a fold as they move along the surface. As they're moving along, they end up digging depressions or grooves as they're breaking down the bone matrix. Now, from they're also secreting a couple of different chemicals. The first thing that they're secreting are lysosomal enzymes and protons, and this helps break down the matrix. The other thing that they secrete is hydrochloric acid, and this converts the calcium salts into a soluble form that gets passed easily into the solution. Now, osteoclasts, they're also phagocytes, demineralized matrix, and dead osteocytes. So the digestive products, they get transcytosed across the cell and released into the interstitial fluid. From the interstitial fluid, it'll then go into the blood. Once resorption is complete, osteoclasts, they end up dying. So they end up undergoing apoptosis, or again, it's cell death, programmed cell death. So these cells, they end up committing suicide, think of it like that. Now, osteoclasts, their activation includes a couple of things. First thing, one of the things that it involves is a protein that's secreted by the T cells of your immune system. In addition to that, parathyroid hormone also plays a role in activating these osteoclasts. So remodeling is occurring continuously in the skeleton. It's regulated by genetic factors and also two control loops. One of them is a negative feedback hormonal loop that maintains calcium homeostasis in the blood. The other, it involves responses to mechanical gravitational forces that are acting on the skeleton. Now, you have to understand that calcium is very important. It serves so many functions in your body and many processes such as nerve transmission, muscle contraction, blood coagulation. So in order for clotting to take place, you need to have calcium. In order for muscles to contract, you need calcium also. And again, for nerve transmission, you need to have calcium. Now, in certain individuals, for example, that are maybe experiencing certain types of depression, now one of the underlying factors may be a depleted amount of calcium. Also, when you look at athletes, baseball players, football players, basketball players, also when people are running or when people are lifting weights, one of the things when they're drinking Gatorade, for example, or again these sports drinks, one of the things that these sports drinks are fortified with is calcium, because again your body needs that calcium to contract the muscles. When you're exercising, there's a lot of muscle contraction going on. So in addition to that, your glands and nerves. Nerve secretions, they're also utilizing calcium. Even cell division utilizes calcium. Now, the interesting thing is that 99% of the calcium is found in bone. And what is that amount? That's anywhere from a little bit over 2.5 to 3 pounds. Okay, so that's between 1,200 to 1,400 grams. That's a lot. It's quite significant. What happens to calcium? How does it get absorbed? Well, calcium is absorbed in the intestines. However, your body needs vitamin D in order to absorb calcium. So when you go to the store, and if you're ever looking at supplements such as calcium supplements, you'll see that majority of the time they're sold as a combination of calcium and vitamin D. So when you look at the hormonal controls, parathyroid hormone, this is produced by the parathyroid glands in response to low blood calcium levels. So when your blood calcium levels drop, it stimulates your body releases this parathyroid hormones, and the parathyroid hormones, it stimulates the osteoclasts to start breaking down the bone matrix. As it's breaking down the bone matrix, calcium gets liberated into the blood, and this raises your blood calcium levels. So parathyroid hormone secretions, they stop when the levels of calcium levels have been reached, when they're within that range that we talked about earlier, that 9 to 11 milligrams per deciliter range. Once that is reached, then the loop stops. Your body stops secreting the hormone. Now calcitonin is produced by parafollicular cells of your thyroid glands. These are called C cells, and this is they also get secreted in response to levels of high levels of blood calcium levels. So calcitonin, again, its effects are negligible, but at high pharmacological uh, doses, it does appear to decrease blood calcium levels temporarily. Now, whether calcitonin has an effect in the body, it's not very clear. The old school thought was that yes, it was, but again, now they're thinking that it's probably doesn't have much to do with it. But then again, they're still figuring out, what is this hormone for? But it does have the potential to uh, decrease uh, high levels of calcium. So when you're looking at this slide over here, essentially it's showing that there's a negative feedback going on here. So remember, calcium homeostasis of blood, it needs to be between 9 to 11 milligrams per 100 milliliter range. All right. So when the blood calcium levels fall, okay, when you have an imbalance, again, so the stimulus is what? The falling of blood calcium levels. It will cause the parathyroid glands. Remember, these parathyroid glands are found on the posterior aspect of the thyroid gland. It causes them to secrete the parathyroid hormone. Parathyroid hormone is going to end up triggering these osteoclasts to start breaking down the bone matrix. When the bone matrix is broken down, calcium gets liberated into the blood, and the blood calcium levels go up. So once the blood calcium levels go up, then it's balanced. Your body will stop sending signals for these parathyroid glands to secrete their hormone. Um, so what's important to understand is even small changes in blood calcium levels can have severe neuromuscular problems. If you have too little calcium, so when you look at this term, low calcium level, so emia, hypocalcemia, emia, the suffix means blood condition, calc means calcium, and hypo means low. So low calcium condition, blood condition of low calcium. What this will cause is hyperexcitability, okay, in neuromuscular tissue. Hypercalcemia, high levels of calcium, this causes non-responsiveness in neuromuscular tissue. Now, when you have sustained high blood calcium levels, this will lead to deposits of calcium salts in the blood vessels or kidneys and other soft organs. So this is going to impair function of these organs. And in the case of kidneys, for example, it's going to cause stones to start forming. So other controls, hormonal controls in calcium levels, so they include leptin, the hormones leptin and serotonin. So leptin, um, so this is a hormone that's released by adipose tissue, okay, so your fat. It plays a role in bone density regulation by inhibiting osteoblasts, okay, from doing their jobs, from bone building. The other hormone, okay, or is serotonin. Okay, serotonin actually it's not a hormone. I'm sorry. Serotonin is a neurotransmitter. Now, this neurotransmitter, it's responsible for mood levels. Also, sleep cycles. It affects your sleep, and it also interferes with osteoblast activity. Serotonin, it's made in your small intestines and is secreted into the blood after you have a meal. It could inhibit bone turnover. Bone calcium, it gets locked in when new calcium is flooding into the bloodstream. So responses to mechanical stress now. So bones, they reflect stresses they encounter. So bones are stressed when weight bears on them or muscles start pulling on them. So when you're starting to lift up really heavy weights, again, you're just exerting a lot more. You're doing a lot more labor, a lot more work. This is going to cause stress on the bones. Okay, because remember, what's happening is the muscles, they're pulling on the bones. Now, Wolff's law, it states that bones grow or they remodel in response to demands placed on them. So stress is usually off center. So bones, they tend to bend. So bending, it compresses one side while it stretches the other side. Now, the diaphysis is thickest where bending stresses are the greatest. Okay, so the diaphysis is thickest where the stress of bending is going to be the most. Now, bone, it can be hollow because compression and tension, they tend to cancel each other out in the center of the bone. So when you look at this diagram here, now what they're showing you is this. So the tension is here and the compression is over here. So the greatest amount of compression is over here and the tension is going to be most over here. In other words, this part's going to be stretching out the most and this part's going to be compressed the most, it's going to be pushed down the most. Okay. Um, yeah. Let's see. So Wolff's law also explains that the hardness, being right or left-handed, hardness results in thicker and stronger bones of the corresponding upper limb. Curved bones are thickest, we're most likely to buckle. The trabeculae form trusses along the lines of stresses. Large bony projections, they occur where heavy active muscles attach. So again, when you're talking about these large bony projections, these trochanterus, for example, again, when you have muscles that are very, when you look at some of these bones, and again, one of the things when you look at it, if you want to differentiate one bone from another bone, versus men versus women, the bulk of the time, majority of the time, when you see these trochanters that are very well defined, again, these bumps that are very well defined, that are much bigger, they're rougher in appearance. This usually tends to be that of males. Again, when men, again, historically, especially when you're looking at, again, skeletons from going back, hundreds of years ago, where men did most of the hunting and when women did most of the gathering. So when you look at hunters and gatherers, for example, again, when men, they were out there doing the hunting, they were lifting really heavy things, they're doing most of the building, and you look at their bones today, you'll see that they're much, much, much more defined when you look at these bumps, for example, these projections, and that's from where these muscles attach to them. A lot more muscle attached to them. So you're going to start to see this, and it helps archaeologists differentiate. So, like they say, weightlifters, they have enormous thickenings at muscle attachments sites of most of the muscles that they're using. The bones of a fetus and bedridden people, they're featureless. You're not going to see anything. Why? Because there's no stress on them. Okay, lack of stress, you're not going to see anything. Uh, so mechanical stress, it causes remodeling by producing electrical signals when bone is deformed. So compressed and stretch regions, they're oppositely charged. Compression and tension, it changes fluid flow within the canaliculi, which may also stimulate remodeling. So hormonal controls, they determine whether and when remodeling occurs in response to changing blood calcium levels. But mechanical stress, it determines where it occurs, right? So keep this in mind. Hormonal control is just going to say, all right, do we need uh, remodeling to occur? Yes or no. Mechanical stress is going to say, okay, you need it over here on this spot, or you need it over there on that spot. Okay, this spot needs to be remodeled much more than some other spot does because there's a lot more stress over here. This part of the bone is being used a lot more than some other part of the bone. So let's talk about bone fractures now. So fractures, they're just breaks in the bone. Now during your youth, most fractures they result from trauma. So or for example, you might be playing basketball, so like sports injury or football, basketball, sports injuries. Maybe you have a fall. Or that'll break, cause a fracture, perhaps a car accident, or end up again you get into a fight and some type of an altercation that could result you know uh, in a in a fracture. In old age, uh, the fractures, they don't really usually occur from, or not necessarily occur from trauma, but they a lot of times end up resulting from weakness of bone. Okay, because the bone is getting too thin. Okay, due to bone thinning. Uh, Now, one of the reasons this may happen, again, there's genetic factors, again, hormonal factors that we talked about. But one of the reasons that this may happen is from a lack of movement, and also this could happen from a bad, insufficient nutrient intake as well. So, especially when you're in your younger age, it's important to get enough calcium in your diet, because that's gonna affect how you're gonna be when you're much older. So you all should be eating at least a glass of milk a day. You should be drinking a glass of milk or yogurt or some cheese, or again, foods that are high in calcium. It's important to have, and that's going to help you later on down the line. As you get older, again, that doesn't mean you can stop. You need to continue to eat. Drink some milk or have some yogurt. Again, the example is milk and yogurt, because these tend to be foods that are high in the amounts of calcium that's present in a serving. Now, let's look at fractures. Now, when you break a bone, again, that's called a fracture. So, yeah, so that was already been established. So, how you classify a fracture? Well, three criteria we can use. So, what is the position of the ends of the bone after the break occurs? So, we're talking about, are the ends of the bone still in position? If it is, then we say it's non-displaced. However, if the ends of the bones, they're not aligned anymore, then we're saying that it's a displaced fracture. All right. Also, we talked about the completeness of the break. If the break is all the way through, all the way through the bone, we call that a complete fracture. If it's not all the way through the bone, then we call that an incomplete fracture. The third thing is we talked about if there's any skin penetration involved in the fracture. If there is, so if the bone is sticking out of the if the bone is sticking outside of your skin, then we call that an open fracture or a compound fracture. If the bone is not sticking out of the skin and is still, enclosed, or in other words, you don't see any blood, if you broke your arm, there's no blood on the outside, then that's we would call that a closed fracture. So a closed fracture, again, that's when there's no penetration of the bone through the skin that takes place. In addition to that, you can also describe these fractures by the location of the fracture, its external appearance, and the nature of the break. So when you look at these next slides, this is called a comminuted fracture. So the bone fragments into three or more pieces. So you tend to see this in older people, again, whose bones they tend to be, not as strong as before. It's a little bit more fragile, more brittle. Now, compression fractures. So this happens when the bone gets crushed. So the example they're giving you over here, they're showing you in the vertebrae over here. So you have these crushed vertebrae. So it is a compression fracture. So again, common in porous bones, so osteoporotic bones, or bones that are subject to extreme trauma, as in a fall. Then you have a spiral fracture. So this is showing you that, again, this fracture is occurring at a spiral. It's a ragged break that occurs when excessive twisting forces are applied to a bone. So it's very common in sports injuries. You'll tend to see this. Epiphyseal fractures. So what happens over here is the epiphysis, it separates from the diaphysis along the epiphyseal plate. So here we go. Remember, this is a long bone. And right over here, you have this fracture that's taking place. So notice that this part is displaced. So again, tends to occur where cartilage cells are dying and calcification of the matrix is occurring. Then you have, sometimes you see these, a depressed fracture. So broken bone portion is pressed inwards. So this is very typical of skull fracture. So, you take a hammer, you hit somebody in the head with the hammer, that could be it could lead to a depressed fracture. There's also something that's called the green stick fracture. Now, green stick, you tend to see this in children. It's very common. So the bone breaks incompletely. Okay, so it's an incomplete fracture, but much in the way a green twig breaks. That's what it looks like in appearance. So what happens is, if you look over here, one side of the shaft is broken. Okay, and the other side it bends. Can you see the bend over there? So this is a green stick fracture. So when we're talking about fracture treatment and repair, a handful of things need to happen. So one of the things when you're treating, it involves reducing the amount of bone that needs to be for your body to repair. So, in other words, you want to realign the ends of the broken parts as close as possible together. You want to realign them, bring them back together as best as possible. Now, this can happen in two different ways. Well, sometimes if the break is not very bad, there's not too much of a misalignment, and again, it depends on the bone and where it happens, but that could be realigned through a closed reduction. So the doctor, the orthopedist, they're going to manipulate, the muscles and the bone back into the correct position. The other option is, it cannot be done through external physical manipulation. It needs to have, it requires surgical correction. So they have to cut you open, and then they have to insert pins, wires, screws to secure the broken ends of the bones. Now, once you've reduced the fracture, what needs to be done is you need to immobilize that bone. Okay, and immobilization is usually done either by a cast or some type of a traction device. And again, you need this for healing. Because if you don't have this cast or traction in place, the bones are likely to move out of place again. If that happens, then it's not going to heal as quickly. It's going to take a much, much, much longer time to heal. In addition to that, there's going to be a lot of pain. In addition to the pain, the bones, they're going to be disfigured. Okay, and that could affect how that limb is. If it's a limb, for example, it's going to affect how it's going to function. You may not regain full motion or full range of motion, for example, if it's an arm or a leg. Now, the time needed for the repair depends on how severe of a fracture you have, which bone is broken, and also it affects. You also consider the age of the patient. So younger people, children, for example, they tend to heal much quicker than somebody that's in their 50s or 60. Also, your diet, your nutrition, what your overall health is, also affects how fast or how well you're going to heal. If you're a smoker, you're abusing drugs, that's gonna it's gonna take, affect how your outcome is. It's gonna take much longer to heal. Now, fracture repair, it involves four major stages. Number one being a hematoma formation. Number two is a fibrocartilaginous callus formation. Number three is a bony callus formation. And then four is finally remodeling, bone remodeling. So the very first step, the hematoma formation. So when you get a fracture in the bone, you end up getting blood vessels that are torn. Okay, so these blood vessels, they start to bleed now. All right, the blood is not flowing within the tubes anymore. So the blood starts flowing all over the broken site. So it's hemorrhaging. It forms a big clot. Okay, and that clot that's formed is what we call that hematoma. Now this ends up swelling up a lot. You end up getting a lot of inflammation over here at the site. In addition to that, it's very painful. All right, whenever you have swelling take place, it starts pushing down on the nerves. All right, and whenever you get nerves that are pushed, that causes pain. In addition to that, remember, you have nerves that, you had a bone, that tissue has been broken, so the nerve endings, they're also been damaged. So that causes that'll cause pain too. So over here in this picture, this is the bone, and notice that you have a blood vessel over here and blood vessel over here, and now they're no longer connected. So what happens? Instead of the blood flowing nicely within this, it ends up spilling all about. Okay, it floods this entire area, and this blood that's now that's gone out of the tubes and now is within this bone tissue is what we call it's formed into a hematoma. So this blood, once it leaks out of the blood vessels, it clots, and once it clots, it forms this hematoma. So what happens next is that usually within a few days, a handful of events leads to the formation of soft granulation tissue that's called a callus or a soft callus. Now capillaries, they grow into the hematoma, and these phagocytic cells, they invade the area and they start the cleaning up process. So they start getting rid of all the debris that's there. So at the same time, you get fibroblasts and osteoblasts that come into the fracture site. from the nearby periosteum and the endosteum, and they start to reconstruct the bone. The fibroblasts, they start producing collagen fibers that'll span the break, and they connect the broken ends. And some of these they differentiate into chondroblasts that secrete the cartilage matrix. So within this mass of repair tissue, osteoblasts, they start forming spongy bone. But those that are farthest away from the capillary supply, they secrete an externally bulging cartilaginous matrix. And this cartilaginous matrix, it calcifies. So this entire mass of this repair tissue is now called this fibrocartilaginous callus. So again, this is a splint. It acts as a splint between the broken bones. So in this drawing, you can see what's happened is that where the hematoma was, you've had these blood vessels that are starting to grow in. It starts to clean up all that the clot that was there, and you have now you can see this external callus and internal callus. So over here also you see the blood vessels been repaired. So essentially, again, what happened was in this step is that uh, so these fibroblasts and osteoblasts, all right, that ended up coming over to the site, they start laying down the fibrous tissue and the cartilage there. So this is what's acting as a splint, as a temporary splint. And then when we go into the next steps, you're going to see what's going to happen at this point. But remember, uh, this is quite clever. It's amazing. Again, you have flexibility over here also. Um, So now the bony callus. So remember, this is what we call the soft callus that formed. Okay. Now the next step is we get this bony callus that forms. Now this usually happens. Now first of all, this part, step two, this usually happens within a few days, maybe 2-3 days. This will happen. Now the bony callus formations, this happens usually within a week. All right. So again, another perhaps 4 days afterwards, 4 days after we had the soft callus, now we're starting to get this bony callus that's starting to form already. So over here, within a week, you get new trabeculae that appear in the fibrocartilaginous callus. So the callus is converted into a hard callus or a bony callus of spongy bone. The bony callus formation, it continues for about 2 months until you have a firm union that forms between the two ends of the bones. So when you look over here, you don't have the fibrocartilaginous tissue over here anymore, or that soft callus no longer present. What you see now are these trabeculae. So this is why we call this a bony callus, not a soft callus, but a bony callus. That's of a spongy bone. So the next step is the fourth step, which is bone remodeling. So this begins during bony callus formation, and it continues for months, maybe 2 to 3 months. Uh, Excess material on the diaphysis exterior and within the medullary cavity is removed. The compact bone is laid down to reconstruct the shaft walls, and the final structure resembles the original structure. So it responds to the same mechanical stressors also. So in other words, what you have now is something that's just as strong as your original bone. You've had a full, complete recovery. So when you look over here now, uh, you had the fracture over here, remember, and now you can't even tell, right? Because it's been replaced completely by new bone. So this is what we said. We have bone remodeling that occurs. So again, this is it's an amazing way, your body ability to regenerate. Fortunately, you have this ability to regenerate this type of trauma when it does occur to bones. Unfortunately, not all body tissues act this way. So, for example, if this happened if you have, depending on which type of nerve you're looking at, nervous tissue you're looking at, you cannot have any repair of that tissue. Or if you're looking at your heart muscle, for example, unfortunately, at this point, there's really is no way to repair heart muscle tissue when it is damaged. But fortunately, again, because people break bones so many times throughout their life, um, it has a way to repair itself. So again, these are just the 4 steps from steps 1 through 4. When you have a fracture and your body repairs it, the hematoma forms. Step 2 is a fibrocartilaginous callus forms, and step 3 you end up getting a bony callus that forms, and step 4 you end up having bone remodeling that takes place. Okay. Now we're going to be talking about bone disorders. Now, just about every disease that we see that affects the human skeletal system, the underlying problem tends to be uh, the imbalance between how much bone is deposited and how much is being resorbed. 3 diseases that we're going to be looking at is osteomalacia and rickets, osteoporosis, and Paget's disease. Now, osteomalacia, when you look at this term, again, osteo is bone, malacia is softening, so bone softening. So the bones are poorly mineralized. The osteoid is produced, but the calcium salts are not adequately deposited. And what ends up happening is you end up having soft and weakened bones. And again, it's quite painful when there's a weight that's starting to be bared on these bones. Now, rickets, it's a form of osteomalacia that we see in children. And so, for example, when you look at the legs, you'll see that these are bowed. So again, when bow-legged, this is an example of rickets. Other bones, you'll see deformities as well. You'll see bones that tend to be enlarged and they tend to be long. Now, what causes this is usually a deficiency in vitamin D, or you're not getting enough calcium within your diet. So again, in these children, you want to start increasing. You want to put them on a supplement, a calcium and a vitamin D supplement. Now, when we see osteoporosis, um, so this is a handful of diseases in which bone resorption exceeds bone deposit. So again, you're getting a lot more bone breaking down than getting bone building. The matrix remains normal, but the bone's mass, it starts to decline. So the spongy bone of spines and necks and the neck of the femur, these are the modes that are most susceptible. So the vertebral and vertebral fractures, again, because remember, this is where you're going to find the spine, right? Spine is made up of vertebral bones. So you tend to see this type of fractures within the vertebrae. Also hip fractures. So when you see hip, again, very common to see the osteoporosis in hips. Um, so here's what normal bones looks like. Notice how nice and strong the trabeculae you see over here are. But in osteoporotic bones, look what's happening. Okay, you see all these little holes and stuff that are present. These are not calcified. So because they're not calcified, again, you have a much less low density of these the minerals, and it's not as hard. So again, what do you have now is now that these bones are very brittle and they can fracture quite easily. Now, what's interesting to note in osteoporosis is that it affects women much more than it affects men. 30% of American women between the ages of 60 and 70, they have osteoporosis. And this number climbs all the way up to 70% in by the time the woman reaches the age of 80. Uh, Additionally, 30% of all Caucasian women are, this is the most susceptible group also, okay, Caucasian women. They'll experience a bone fracture due to osteoporosis. So again, 30% of women, they end up having a fracture. So again, the bone, it just becomes so brittle. So I don't know, for example, if you step off of a curb, all right, and that can fracture your bone. And again, the hip bone, it tends to occur more. Now, it's not your hip that's actually breaking, but again, it's that neck of the femur, which is connected to the hip. The head of the femur goes into the acetabulum of your hip bone. Your so Now hormones also, they play a role in this. So in women, one of the things that they do is, they start estrogen hormone replacement therapy, estrogen. So, when you have estrogen, it tends to offset, osteoporosis. But then again, estrogen, now there's a whole new debate or thing about estrogen and how it could cause cancer, et cetera, or high doses of it. my personal take is, if your body is not producing, again, in women, uh, estrogen levels, again, they drop off after a certain age. And again, this is natural. This happens due to nature. Uh, so why go against nature? This is my thinking of it. Once you start messing with Mother Nature, you start running into problems. So I discussed this already in the previous slide, but we'll just go over it again. I didn't know they had a slide for this, but so yeah, risk factors for osteoporosis. Most often, uh, you'll tend to see this in postmenopausal women. And again, it's the women that are affected, not so much as the men. So 30% of all women between the ages of 60 to 70 years old are the ones that are affected with osteoporosis. And 70% of these women, they go up to, this number rises to 70% by the time they get to age 80. So an 80-year-old woman has a 70% chance of developing osteoporosis. Now, 30% of Caucasian women will suffer fractures, okay, because of osteoporosis. And as we said earlier, estrogen plays a role in bone density. So when levels drop at menopause, women risk higher risk of developing osteoporosis. Again, men less prone due to the protection by the effects of testosterone. So testosterone levels, they tend to, you know, stay just about the same. You're not be producing as much testosterone, but again, there's enough testosterone that's being produced in men. Uh, like, um, so again, men don't have to worry about this too much, but men have other problems aside from that. So additional risk factors for osteoporosis. If you have a petite body form, again, higher risk of developing osteoporosis. If you've been lethargic most of your time, okay, insufficient exercise to stress the bones. So if you're not walking, all right, you're not doing any type of exercise, this is going to end up, it could increase your risk for developing osteoporosis. So again, it's very important to walk. Go out and walk at least 30 minutes a day, 40 minutes a day, minimum. Not only is it good for your heart health, but it is also good for your bones, for keeping to saving yourself from developing osteoporosis. Again, we talked about nutrition. So if you have a diet that's poor in calcium and protein, that's going to increase your risk of developing osteoporosis. Also, smoking. Cigarette smoking is awful. Cigarette smoking affects bone density also. So again, could contribute to osteoporosis. We talked about estrogen and hormones, how they play a role in bone density and bone formation. Well, hyperthyroidism can also affect your risk of your osteoporosis. Low blood levels of a thyroid stimulating hormone, in addition to that, diabetes, mellitus, all these will affect your chance of developing osteoporosis. Again, like I said, if you're not exercising enough, okay, if you're just staying at home, you're not moving, you're bedridden, for example, immobility, it increases the risk of osteoporosis. If you're taking certain medications, certain drugs, like men with prostate cancer, again, that can increase your risk factor for developing osteoporosis. Now, how do you treat osteoporosis? So traditional treatments, what they've done, again, in women, it's a good idea, again, after 50, age of 50, to start taking a calcium supplement with vitamin D. Now, remember, if you don't have vitamin D, the body's not going to be able to absorb calcium. So again, especially in Chicago, where, it's mostly cloudy and cold and wintry 10 out of 12 months, and you may not be getting enough sunlight because your body produces vitamin D when it gets stimulated by sun. So again, if you're not getting a sufficient sunlight, and you need about 15 to 20 minutes of sunlight a day. If you get about 15 to 20 minutes of sunlight a day, then you should be okay. You should have sufficient amounts of vitamin D. So when you get enough vitamin D, your body's going to be able to absorb that calcium. So again, women, they'll be prescribed by their doctors calcium and vitamin D supplements. In addition to that, do some exercises. Running is good, jogging is good, even lifting light weights, that's very helpful also. Again, hormone replacement therapy, it slows bone loss but does not reverse it. It's, again, I told you, there's controversial risks. I mentioned to you cancer. Again, estrogen, yeah, it's
been shown, it's demonstrated that, it could raise your risks of breast cancer. In addition to that, heart attack and stroke are among the risk factors for taking these estrogen replacement hormone drugs. I don't know. My advice is, again, talk to your doctor, but probably better to try some alternative, stick with a healthy diet and exercise. Now, uh, bisphosphonates, these decrease osteoclast activity and your numbers, so it partially reverses osteoporosis within the spine. Now, selective estrogen receptor modulators, they mimic estrogen without targeting breast and uterus. So again, this is something that they're using. They think that it might be a little bit safer to reduce the risk of developing cancers in breast and uterus. Denosumab, it's a monoclonal antibody that's shown to reduce fractures in men that have prostate cancer. It also improves bone density in the elderly. So preventing osteoporosis, make sure you have a good diet. Okay, make sure your diet is high in calcium, especially in early adulthood. Remember, what and how you live your life in during your young years is going to affect as to how you are in your later ages. Having a diet that's high in calcium, vitamin D, and also you're getting adequate amounts of protein, this is going to help prevent osteoporosis. Also, cut down on your consumption of carbonated beverages and alcohol. Eliminate this. This is no benefit at all. If there are any benefits, for example, some people say, oh, a glass of wine is good for you. Well, you know what? The harm that it does outweighs the benefits that it provides. All right. It should be avoided. It's not healthy. These things, among all the other havocs it causes in your body, uh, in bone specifically, it leaches minerals from the bone, so it decreases your bone density. uh, Also, make sure you're getting enough weight bearing exercises. Uh, like I said earlier, go out. You should be walking at least 30 to 40 minutes a day. 40 minutes, the more the better. But don't do more than you don't need to do more than 40 minutes a day. Go out for a walk. Lift some weights. So this is going to help increase your bone mass above normal for to act as a buffer against age-related bone loss. In Paget's disease, this happens when the bone is made too fast and poorly. So you end up having excessive and haphazard bone deposits and resorption. So again, we call this a Pagetic bone, and what it has is a very high ratio of spongy to compact bone and reduced mineralization. Now, this usually occurs in the spine. You find this in your pelvic bones, your femur, and your skull. Rarely does it happen before the age of 40. They don't really know what causes it, but they're thinking that it may be due to a virus. Treatments usually include calcitonin and also bisphosphonates. Embryonic skeleton, it ossifies pretty predictably. So if the fetal age is very easily determined when you look at a sonogram or an X-ray for that matter. Now most long bones, they start to ossify right around 8 weeks. When then right around the 12th week, you start to see these primary ossification centers that are developed. Um, so, from birth to young adulthood, at birth, most long bones are ossified, the exceptions being at the epiphyses. Now, the epiphyseal plates, they persist throughout childhood and adolescence. And again, remember, what did we say? Right around age 18 in the females, the epiphyseal plate, it's sealed, there's no more cartilage. And at around age 21, you find that in males. Well, again, remember I said it varies, so anywhere between 18 to 21. But again, in certain cases, certain instances, it can occur up to age 25. So usually by age 25, all bones are completely ossified, and the skeletal growth stops. So when you look over here in this photo, uh, again, this is a roughly 12-week-old fetus that you're looking at. So you can see the parietal bones. Now the darker areas, this is where primary ossification has already occurred. This is the tibia. I'm sorry, this is the femur. This is the tibia over here. This is the fibula over here that you see. This is the radius. This is the ulna. You can see the digits. These are this is the collarbone, the clavicle. This is the shoulder blade, the scapula. Uh, Anyway, you can see the backbones over here, some of the backbones. This is a finger, by the way. It's not a backbone. These are the backbones over here. These are the ribs. And this is the part of the hip bone. Now, in children and adolescents, bone formation it exceeds resorption. Okay, in children up to adolescence. Now, men compared to women, they tend to have greater mass. Okay, men will have a greater mass than females. In young adults, the amount of formation and resorption is relatively balanced. Now, in adults, okay, what ends up happening is resorption it excretes. Resorption it exceeds a bone formation. So bone density changes over lifetime. They're largely determined by genetics. So a gene for vitamin D cellular docking determines mass early in life and osteoporosis risk at an older age. Bone mass mineralization and healing ability decrease with age beginning in your 40s. The exception is being the skulls of your bones. Bone loss is greatest, again, in females and within the females, in white females specifically, moreover. So this is it for chapter 6. I hope this helped. If you like it, please give it a thumbs up. If you have any questions, please leave it in the comments below, or you can email me directly. And please feel free to share with your friends. Thank you so much for watching.